Thank you for asking me to speak today, and a little bit different, but moving on from Krabbe to another leukodystrophy, metachromatic leukodystrophy. I'll keep it to 15 minutes in the interest of time. But very quickly, just to set the scene before I talk about gene therapy, is to just give you a flavor of how difficult it is to diagnose MLD. So these are two different cases. The first case is a very classical case of a child developing until about just 2 years of age. And the parents report this child's always been clumsy, become more clumsy, seen by a pediatrician and been found to have some stiffness in the lower limbs. Couple of months later, starting to lose some speech, becoming unsteady and regressing effectively. And when the pediatrician sees this child again, the child has become very floppy, with some stiffness in their limbs, and starting to have some swallowing difficulties as well, and ends up having brain imaging. And, you don't need to be a specialist, but the main thing to point out here is this very bright white area, which I'm just highlighting here with my mouse, which is a very classical leukodystrophy. And when you see that in this age group, you would think that this would be likely to be MLD. And the second case, slightly different, is a 7-year-old girl, concerns being raised for a few years, really, that she's had a slight tremor, a bit clumsy, and maybe needing some extra support in school. So very subtle things, no real regression or loss of skills reported. But she's seen with a relatively wide gait. So she walks really, with a wide-based gait, and she's got some foot drop, and she's got some increased reflexes. So like the first child, but much more subtle. And again, some slurred speech, a bit of a tremor, and she's got a completely normal MRI scan of her brain. So no evidence of leukodystrophy on her scan. But she's got some abnormal peripheral nerve conduction studies pointing towards there being a problem. And she also has MLD, but you can see that they present quite differently. So just to tell you a little bit about MLD, it's a recessive condition with a mutation in an ARSA gene, causing a deficiency in an enzyme, leading to accumulation of sulfatides, which are bad. They deposit in the central and peripheral nervous system and cause progressive neurological decline. And sulfatides are these brown stars, which I'm just pointing out here, which you can see in these yellow bits and also in the green bits. So they deposit in the nerve cells, and they're effectively toxic. And unfortunately, that leads to progressive toxicity and neurological decline. And there are different types of MLD. The most classical is the late infantile type, which is the majority that we see. And they normally have very low ARSA enzyme levels, and very aggressive. Most of these children pass away in the first decade of life. The early juvenile normally presents between 2.5 years and 6 years of age. The ARSA level is low, but a little bit different. So this is like that second case I showed you, the girl who presented from about the age of 4, gradually having symptoms, may not have regressed so much. And their outcomes are a little bit better, but unfortunately, they all decline, and eventually they pass away. But if you look at their first decade survival, half of them are alive, but with significant neurodisability. And then there's a bit of the unknown in the orange box of late juvenile and adult, which I think we're still learning about because these are rare and they can present with very various features, could be sometimes even neuropsychiatric features, and no one really knows because we don't have enough data on this. And this is just to show you that there can be so many different symptoms which can present as the first sign of MLD. And they could be change in behavior, developmental problems, memory issues, learning difficulties, sleep issues. So it is not easy for a pediatrician or a GP or an A&E physician to think of MLD when someone presents with this. A lot of them are diagnosed with just global developmental impairment of unknown cause, or dyspraxia, or ADHD, or ASD. So people may not think of MLD early enough. So normally, classically in the past, pediatricians would think about MLD once they have done an MRI scan on someone who's losing skills and they see the classical changes like I showed you in the first scan, where they see some white matter changes pointing towards a leukodystrophy. But actually, that is not fast enough for treatment, as you will see later on. And we are trying to move away from imaging and saying that actually we need to diagnose these children very quickly using enzyme tests. And we do use genomic tests, just like many other leukodystrophies, when there are concerns that we are not sure, or could this be a pseudodeficiency? This just shows you that the natural history of MLD is awful. This first area where my mouse is the late infantile MLD, and they just basically go downhill very quickly in the first few years of life. And then you've got the early juvenile and the late juveniles where they have a stepwise decline over years, but they all end up doing very poorly. So your GMFC scale, which is looking at your level of disability, 0 meaning that you're completely fine, and 6 meaning you are basically bedbound with no head control, shows that actually most of them end up in that stage, whatever the phenotype is. So why is this important? So a few years ago, there was a different gene therapy for spinal muscular atrophy, which was revolutionary for us. And that was, a big breakthrough for the neuromuscular team to try and change the phenotype for spinal muscular atrophy for children who previously died within the first year of life, who are now walking at the age of 2 or 3. But now we are making way for the most expensive drug, which is being used in the NHS, which is LibMelD, which has been licensed to be used for MLD. And why is it important? I guess we are using it here in Manchester as the only center in the UK and one of 5 European centers licensed to be using this. And this has just been started for just over a year. So we're now 14 months into our license of using LibMelD. And why have we ended up with gene therapy? It's really because other things have failed. So we did try enzyme replacement therapy and just could not get that working for MLD. It works for some other conditions, but was not sufficient for MLD. Even bone marrow transplantation, very interestingly, was stopping the central nervous system disorder, but it did not help the peripheral nervous system side of things. So if a child had BMT with MLD, they would have preserved central nervous system problems. A lot of them do not even develop the scan changes if they have it early enough. But unfortunately, they all progress peripherally. So they end up having the spasticity and eventually do die from complications of the severe spasticity and chest problems. So not good. And we found that normal enzyme levels, when you replace them, are not enough. And a bone marrow transplant delivering normal ARSA levels is still not enough. And then there are, of course, other options which we're thinking, should we be thinking about intracerebral gene therapy with a viral vector? And that was being tried and again was unsuccessful. So then, a lot of research went into LibMelD, which has really revolutionized how we think about delivering gene therapy. So what is being done is that the cells are being collected from the own patient, and that stem cells are then purified, and you then insert a working copy of the gene. So the working copy of the ARSA gene is inserted into cells, but then what you're doing is you're turning up the switch for the gene to about 100 times of normal, because we've already learned that BMT is not working for these children. And therefore, we know that normal enzyme levels, even if you replace them, is not enough to stop progression. So we're delivering 100, and in some patients, up to 1,000 times the normal ARSA levels. And when you check them, but we know that that's not toxic. And then you put it back into the patient. They need to have some chemotherapy to be able to receive it, but they don't get any problems in terms of graft versus host disease because it's their own autologous cells. And then that goes in and starts engrafting and proliferating. But some people are still skeptical and say, is it really without any problems? And the main study came from our colleagues in Milan, which looked at the open label phase 1 and 2 trial. And they enrolled 29 patients and versus 31 controls. And most of them were pre-symptomatic late infantile and a few early juvenile, early symptomatic patients. And 90% of them survived. There were 2 who died. One actually died from a stroke. So completely unrelated and very unfortunate event, but actually was not related, but was reported. And the other one who unfortunately passed away was a child who had early juvenile MLD, but was going off legs. And when they were giving the LibMelD, the child had gone off legs already. And unfortunately, that child's progression was hastened by giving LIPMLD, and the child died even quicker than expected. So there were some learning points from the trial about who we should be selecting to give gene therapy to. And this just shows that actually you can see, compared to the children who were not treated and the ones who were treated, the ones who were treated were doing really well from a total GMFM score. They were all really mobile and doing well. And the ones who were not treated were the ones, as I mentioned, who were progressing very rapidly and dying. Side effects to know is that it's generally very well tolerated. There is chemotherapy that they have to be able to receive their LIPMLD with their cells again. So they can get obviously some neutropenia from that and get some problems with infection, but there is no graft versus host disease because you're getting your own cells. And it removes what we were doing with other gene therapies like Zolgensma for spinal muscular atrophy, because you don't get the viral related risk of the fever or liver problems. But again, there is always an issue when, no matter what you do. So the main problem with LIPMLD is that it takes about 6 to 8 weeks for the stem cells after harvested to be modified. And that is really the quality control from Orchard Therapeutics and making sure that, it is working, the genes are delivering enough enzyme levels before it's given back to the patient. And of course, the worry is that in that 6 to 8 weeks, they could progress, especially if they are symptomatic early juveniles. And we know that already from the trial that if you give it to someone who's already progressing, that could accelerate deterioration. So we have got an MDT in Manchester so that we carefully select patients, and the selection criteria is the same internationally. And we've got myself here, and then Professor Simon Jones, our metabolic consultant. At the bottom here on the left is Professor Rob Wynn, our hematology consultant. And then we've got Stuart Russ, our neuropsychologist who works with us. And we see all patients who are referred in the UK straight away in an MDT fashion. And we would offer LIPMLD for a pre-symptomatic late infantile disease patient, which means that the only way they could get diagnosed currently in the UK is having an older sibling who is already affected, unfortunately. So it's really what the families tell us is that the older sibling is saving the younger sibling's life. Or if they have early juvenile disease and they're able to walk independently and take some steps across the room, and they must have an FSIQ of greater of 85. Again, from the trial, we realized that if they didn't, they continued to progress. And the key here, as you can see, is that it's not good enough. I mean, we are in 2023, and what we are offering is life-saving disease-modifying treatment to an infant, and the family are going to watch the older sibling pass away. And it's really hard, and we're trying to shift away from this. So the first child in the UK who received it was a child who had late infantile MLD already, so couldn't get it. But her younger sibling, who was asymptomatic, received it at the age of 1. But as you can see, the tragedy is there for the older sibling, unfortunately. And in the 20 patients we've screened so far in the past year, only 4 have been eligible and been offered treatment. And 2 of them were late infantiles, one which you saw the photo of, and the other one who's been offered it at 5 months of age because was diagnosed antenatally already, that we knew. And as soon as the child was born, we waited for the child to get to about 5 kilos when our hematologist was happy to offer the gene therapy. And we've offered it to a couple of early juvenile patients as well. But this is the sad slide, that despite showing you that we had 4 patients, there were 16 patients who we could not offer it to, and the majority of them who were discussed were actually late infantile MLDs. So they were already symptomatic, and therefore we can't offer it to them. And the only way we can move forward from this in the UK is to have newborn screening, which we are really trying to champion. And I'll just tell you a very quick caveat because, hot off the press, our team in Manchester are working very, very hard to try a pilot program within Manchester, where we are collecting samples from newborns and just general newborns from parents who are consenting for it. And just yesterday, sample number 200 tested positive. So this is a newborn who's tested positive and genetically has been shown to have likely to have late infantile MLD. So we'll be contacting the parents over the next few days because this was unexpected. But hopefully we might be able to prove to governing bodies that newborn screening can make a difference. So we're hoping that this pilot we're doing in Manchester will help to spearhead newborn screening for MLD in the UK, which will be the only way we can offer, a fair deal to all patients who are pre-symptomatic late infantile MLD. So we're trying to do that, but as you know, newborn screening is very difficult. But hopefully, what has happened yesterday will be a first step, a positive step towards newborn screening in the UK. In the meantime, we are getting pediatricians to be really alert and be looking out for MLD, and we are letting them know that they need to recognize MLD early. Think about enzyme testing rather than waiting for scans. So if they suspect anyone has MLD or they're wanting to screen a younger sibling, the enzyme testing should be done very quickly, and we can get a diagnosis within 48 hours on that at most. And all patients in the UK should come to our MLD service, whether they get treatment or not. So they get same streamlined advice. And, we're trying to move towards screening all asymptomatic siblings, newborns, fetus, just giving family genetic counseling to try and make sure that they understand that if they have a future affected child, we can offer gene therapy. And the window to intervene is too short, really too short at the moment. So this message is going out there that, we need to test everyone, screen for asymptomatic siblings until we get newborn screening. But in the meantime, we are left with, offering newborns, offering LibMLD for the patients who are asymptomatic siblings of late infantile or very early symptomatic early juvenile. But the hope for the future is hopefully we'll have newborn screening and be doing things very differently in the UK. But that is the hope rather than a definite promise.